fluid status, fluid responsiveness, and fluid tolerance presented by Group E. So just a disclaimer, this is not an echo course. This is just to tell you why we do what we do and how to adequately resuscitate your patient without giving too much fluid or too little fluid. So what are the dilemmas that we face in our ED when patient comes in? So when the patient comes in hypotensive, we don't know what's wrong with the patient. Are there overlapping forms of shock? Should we start on vasopressors? What is the expected cause of this patient? Should we keep on giving fluids? So how do we answer all these questions? So first of all, the most important part is, of course, your history taking and your clinical examination. That goes hand in hand with your ultrasound maneuvers later on. Evaluation and management of intravascular volume are a central challenge in caring for the critically ill. Patients with hypotension are commonly resuscitated with IV crystalloid fluids in keeping the recommendations for treatment of many shock states. The therapeutic goal of fluid administration is to increase your preload or the stressed venous volume, leading to an increased stroke volume and cardiac output. There is increasing data to demonstrate that excess fluid administration may be harmful and is associated with increased mortality. Large volume resuscitation promotes endothelial injury, fluid extravasation, and tissue edema. So this is what we are trying to avoid in the patient when we are resuscitating the patient. And there's been studies done showing that in unstable patients, approximately only 50% of fluid boluses, 50% of the patients that receive fluid boluses fail to improve their cardiac output. So in theory, that's a large number, 50%. Half of it will not improve with cardiac output, of their cardiac output with fluid boluses. So throughout the years, clinicians have used many parameters to try to adequately resuscitate patients. Such as looking at the BP, the heart rate, your CRT, your urine output, but clinical examination done alone has proven unreliable. So over the past 2 decades, investigators have sought to improve techniques and tools. So there are 2 types of tests that they to see patients' clinical status. They have the static test and you have your dynamic test. Static tests such as your heart rate, your BP, your CRT, CDP, and your SCVO2 and your lactates, they can indicate tissue hypoperfusion. But what they don't tell you is whether the patient will respond to fluids. It doesn't tell you whether the patient can advance in the French-Starling curve. That's what you want to know. So that's where our dynamic tests come in, such as your passive leg raise, your SV, your stroke volume variation, your pulse pressure variation. So echocardiography is an essential tool for guiding resuscitation in critically ill patients. As I said, resuscitation often requires the IV fluids. Although the purpose of fluid resuscitation is often to increase cardiac output, blood flow is not routinely used to guide resuscitation. Sufficient mean arterial pressure is rightly targeted, but is proportional to flow only for a given systemic vascular resistance, which is a dynamic component of circulatory state. Echocardiography is an evidence-based approach and ideally suited to address this problem. So echo is used as a hemodynamic monitoring tool. So these are just some of the journals and articles that came out to show that your CVP and your SCVO2 are not reliable indicators of whether the patients are going to be fluid responsive. They indicate that patient may be under volume and may benefit from fluid boluses, but it can't tell you in which part of the French-Starling curve the patient is. So what is ecodynamics? So echo is, as I just said, we use it as a hemodynamic monitoring tool. How do we use it? We use it as a qualitative assessment and as pattern recognition strategies. So when a patient, as I said, when a patient hypotensive comes into your ED resus, you look at the clinical examination you look at the history, and then your ultrasound is right there. You can use your ultrasound. This only takes a few minutes. You have something called the rush exam protocol. For the rush exam protocol, you look at the heart, your IVC, your abdominal cavity, your aorta, and your pulmonary. So this is to see what kind of shock the patient has, whether it's hypovolemic, whether it's obstructive, whether it's distributive shock. So just doing this, really few minutes, the time you take a few minutes to do the rush protocol will help you in treating your patients. So after you have determined that, okay, I think patient is hypovolemic, okay, he could either be in sepsis or he could be bleeding out. If patient is bleeding out, don't wait to transfer. You can see blood pouring out of the patient, please give blood as needed. But patient has no obvious source of hypovolemia. There's no obvious bleeding. Vomiting, diarrhea, maybe a little bit. So how do you know? But you think patient is hypovolemic from the heart rate, the BP. So you can use your focused cardiac ultrasound to find out if this patient can be resuscitated with fluid pulses. Okay, so these are just some videos. Maybe you guys can tell me. This is a video of the. Anybody? Okay, this is a video of the heart in a subsystolic view. So you can see all 4 chambers and also the liver at the top. This is a video showing the abdominal aorta. It's huge. It has a false lumen. So you can suspect aortic aneurysm. And if patient is hypotensive, probably patient is bleeding from the, you can find out the cause of the hypovolemia. And this is a video of our inferior vena cava. As you can see, with the variation of inspiration and expiration, the IVC collapses and extends accordingly. And this one shows that fluid in the Morrison's pouch. So probably patient has hypovolemia from intra-abdominal injury. So this is another video showing of inferior vena cava, but in this video you can see that the IVC is plethoric. There's no variation in the diameter of the IVC. And this
In pulmonary hypertension, the right ventricle dilates and hypertrophies in response to pressure and volume loading, as can be seen in this apical 4-chamber view.
And it's having a septal bowing and affecting your left ventricle filling. And another video down here, this is in the short axis view, and also showing RV is dilated and pushing into your left ventricle. Okay, so now we go to the physiology basis of fluid resuscitation. The ultimate goal of resuscitation with fluids, vasopressors and inotropes is to ensure adequate oxygen delivery to prevent or treat organ dysfunction. So what we want to do is to deliver oxygen to your tissues so they don't die. So the oxygen flux formula is your oxygen delivery depends on your cardiac output, oxygen binding capacity, your hemoglobin, your oxygen saturation, and also your amount of dissolved oxygen in the blood, your PaO2. So for this, HB, you can just look at your full blood count. You can what it is. For your SaO2, you can look at your SpO2 monitoring. You can get what the value is. And for your PaO2, you look at your EVG. But how do we get cardiac output? That's what we want to know. So your formula for cardiac output is stroke volume times heart rate. Your stroke volume depends on your afterload, your preload, your contractility, and your afterload. And your mean arterial pressure equals to your cardiac output and your systemic vascular resistance. Okay, so all this I will, what we want to do is, when we fluid resuscitate the patient, the most important law right now is your Frank-Starling law. So I'm sure everybody knows what this curve is. Everybody has seen it in their medical lifetime. So Frank-Starling law, it states that the length of myocardial tissue is directly related to the force of contraction. The more we stretch the muscle fibers, the more it contracts. And when it contracts more, it ejects more blood out into the aorta, which should increase your stroke volume and hence your cardiac output. So when we are looking at a patient that's hypotensive and in septic shock, what we want to know is in which part of this Frank-Starling curve the patient currently is, and is the patient able to progress through the curve. So if the patient, as you can see this diagram, let's see if the patient is at the ascending part of the curve and we do a dynamic test, as in we give a fluid bolus, be it with an intravenous fluid or with your passive leg raise, even a little bit of fluid given will increase your stroke volume by 18%. Okay, if the patient is around here. But if you see, if the patient is more towards the plateau of the curve, this amount of fluid only increases your stroke volume variation by this much. So at this point, you have to think, is it good for me to give more fluids to the patient? Will I do more harm or will I do good to the patient? Okay, so this is what we want to know. So if the patient is on this part, we want to see if the patient can go up here and increase the stroke volume and cardiac output when we resuscitate with fluid bolus. So according to Guyton, your venous return, which is your preload, equals to your mean systemic pressure minus your right atrial pressure over your systemic vascular resistance. So our mean systemic pressure is regulated to a great extent by the effect of sympathetic nervous system on the splanchnic venous system. It contains 20% blood volume and 30 times more compliant than arterial circulation and heavily innervated by alpha adrenal receptors. So what this is telling you, when you look at this diagram, so this is about stress volume and your venous return. So when I say stroke volume depends on your preload, contractility, and your afterload. So how do we increase our preload? We increase our preload. So let's say this is your wings, and this is your IVC going into your right atrium. This is your right atrial pressure. So in theory, you can increase the flow of the blood into your IVC and increase your afterload if your right atrial pressure reduces, or if you increase the fluid amount here, or you reduce the diameter of the wings. Okay, so our basis of giving fluid bolus is currently these are your this is the amount of blood in your wings. So this is the stress volume. Only this amount of blood is going into your IVC, going into your afterload to become your afterload in your right atrium. So when we try to give fluid bolus, we increase the amount of stress volume, hence more volume into the right atrial atrium, which increases your afterload. And if your afterload increases by right, your contractility of your heart left ventricle is supposed to be better because it is stretched. And more stretch causes more forceful contraction for the left ventricle and increase in your afterload and your cardiac output. Another way is to use inotropes to vasoconstrict the vessels. This pushes the unstressed volume to become stress volume and achieves the same theory. So this is the basis of fluid boluses. Why we give fluid boluses? So now comes the dilemma of, can I give it to the patient without harming the patient? So this is where your echo comes in. Why echo? Why not other things? There are other measurements, but usually your SVV and your pulse pressure variation and your stroke volume variation, it requires an arterial line, and it requires certain machines to do the calculation for you. So it's invasive. Ultrasound nowadays is readily available in all EDs. It's fast and it's non-invasive. So what do we assess for? When we look at the patient, we assess for the LV systolic function, assessment of fluid status, assessment of fluid responsiveness, assessment of fluid tolerance, and assessment of right ventricular systolic function. Okay, so as I said, when we look at the patient, we look at the LV systolic function, we want to know at which part of the Frank-Starling curve the patient is. Whether it's at the steepest part or the less steep part. Okay. And whether the patient is at the steep part or the less steep part. So we can look at the left systolic function in ED. Most of us have not gone for an advanced echo course. So what we do is we do qualitative assessment. We do eyeballing method. This is fast, easy, and if you do it often enough, you get good at it. So at the first video here, you can see, okay, what can you tell me about this heart? Anybody? Any ideas? Poor contractility. Okay, why we say poor contractility? We say poor contractility because the LV wall, you can see your anterior mitral leaflet is not even touching the septum. And you can see your ventricles here, they are not collapsing towards each other. So you can, so in your opinion, can this patient take fluid? We don't know yet. Maybe, maybe not. So you have to do more exams to determine. But looking at this, you're going to be cautious about the fluid that you're going to give this patient. And then look at this heart. This is a hyperdynamic heart. Oops. So you can see this one, the heart is hyperdynamic. The mitral leaflet is touching the septum. So this patient, I think that patient definitely can take fluid. So you will see whether it's fluid responsive in the next other scans that we do. So this is what we call qualitative assessment. This is what we do in ED. It's faster. And you don't need to be an expert in ultrasound. Another option is to do quantitative assessment. This is where you look at your picture one is showing your LV fractional shortening. So this one is the cutoff point of 30%. You have to measure the diameter of your LV during systole and diastole. Okay, this is EPSS. EPSS is easier to do. And it's easier to estimate the ejection fraction of the patient. Let's say you're not good at eyeballing, you just want to know what is the estimated ejection fraction of this patient. EPSS is the easiest thing to do, is your E point septal variation, septal separation. So this one is you get the heart view in your long axis, and then you use M mode, you put your cursor at the anterior leaflet of the mitral valve area. And then you pause and you will look, you can see the drawings, the mitral valve, anterior leaflet and posterior leaflet, and your septum. So you count the space between them, the distance between the septum and the highest part of your curve, and you'll get your value. If the value is less than 6 millimeters, you can X expect the ejection fraction of the patient to be more than 50%. And if the value is between 6 millimeters to 1 millimeter, your expected ejection fraction is 30 to 50%. And if it's more than 1 millimeter, your ejection fraction is less than 30%. And the other one at the bottom is the Simpson's biplane, which is difficult to do. So you want to learn all this, please join an advanced echo course. Okay, so here we come. Fluid status of the patient. Does he or she need fluids? So what we can do is, as I said, we use a static hemodynamic parameters to estimate if someone needs fluid or not. What we look at is we look at the IVC. Just now I showed you a picture of two different kinds of IVC. One that was kissing and one that was already plethoric. So the kissing one, we can say that patient needs fluid. Definitely, most probably, will respond to fluid, but we don't know yet. But looking at the fluid status, I'm not so scared to give fluid to the patient. If I see a plethoric IVC with no variation, I'll be scared to give fluids. I'll be very cautious. Okay, so we will look at other parameters because IVC is not one parameter that you look at. It's not standalone. You have to look at the whole big picture of it. So after we look at the IVC, another thing that we can look at is the left ventricle and diastolic area. Left ventricle and diastolic area is good if it's at the extremes of a patient. If patient is very hypovolemic, you can see at the end of diastole, the left ventricle is still very small. The area is small. So what it says is that patient most probably can take fluids because with this kind of small end diastolic, at the end of the filling, the left ventricle is still under volume. It says that your preload is not enough. So if you increase your preload, you might increase your cardiac output. Okay? And if you see a left ventricle end diastolic area that is large, maybe the patient is not fluid, does not need fluids. So it helps in the either extremes. But what the problem we have is like patients like, it looks normal. Can I give fluid? Can I give fluid? Maybe. So what we look at next. So this is assessing fluid status of the patient. Does he or she need fluids? Next we want to do is okay, so this is your IVC. As I said, if you see IVC less than 1 centimeter, patient is hypovolemic. If you see an IVC of more than 2 centimeters, patient probably hypervolemic. Okay. And this is how you get your IVC. You can use your cardiac probe or your curvilinear probe. And the most important thing is when you're doing IVC, you need to see the right atrium. Okay. If you're not seeing the right atrium, most probably you're not looking at your IVC, you're looking at your aorta. So you have to correlate your findings with the clinical presentation of the patient. If patient is coming in tachypneic, heart rate is tachycardic, hypotensive, but then you see that IVC is like super distended, but patient has no heart problem, then you have to think, was it an IVC or was it the aorta? Okay. So as you can see here, IVC is pretty much collapsed, kissing. Okay, so fluid responsiveness. Fluid responsiveness is whether patient can be given fluid. Can he or she be given fluid? Assessment of intravascular volume status and the likelihood to respond after a fluid challenge. It's extensively studied in sepsis, and it uses Doppler study of the heart to estimate your stroke volume or your cardiac output. So this is your important part. So now you think your patient can be given fluid. So now you want to see if giving fluid is going to benefit the patient in increasing his stroke volume and cardiac output. So again, you come back to your Frank-Starling curve. Your very important curve. So you want to add. So how we see if patient is fluid responsive is, as I said, if we give like a mini bolus of fluid, or we use our passive leg raising, when we look back at the physiology of it, it will increase the amount of fluid in your veins and increase by right your preload. So if after giving fluid, you have to assess certain parameters prior to giving fluid and after giving fluid. If there is an increase in your stroke volume by more than 15%, it means patient is fluid responsive. Okay, so that patient has the ability to ascend the curve to a certain point of your Frank-Snellen curve until the patient cannot take fluids anymore. So as I said, you have to monitor the change in SV, and fluid responsiveness is defined as an increase in stroke volume by 10 to 15% after fluid challenge of 250 to 500 mils over 10 to 15 minutes. Okay, so you check the stroke volume prior to giving fluids and 15 minutes after you give the fluid, for 15 minutes immediately. Because as we know, fluids don't stay in the body for long after we bolus a patient, especially in septic patients. They tend to dissipate into your interstitial fluids. So this is looking at your IVC. This is a study done. So for spontaneously breathing patients, we use the Collapsibility Index to see whether your IVC is whether it's plethoric or not. So in Collapsibility Index, you get your IVC, you use the M mode and you put the cursor at your IVC, and you can get the variations. So you count the biggest diameter and the smallest diameter. So the D max minus your D min over your D max. If it's more than 15%, patient can probably take fluid. And in ventilated patient, we use the Diastolic Index because in ventilated patients, you're getting positive pressure ventilation. So when you inspire, the IVC collapse, IVC distends and collapses during expiration in ventilated patients. So that's when you use your D max minus D min over your DB. Okay, so if it's more than 18%, patient can still probably take fluids. Okay, but as I said, looking at IVC is, you cannot look at IVC alone. You have to look at other parameters as well. So the best way to look at your stroke volume is to look at your left ventricle outlet tract velocity time integral. This will tell you what your stroke volume is and your cardiac output in a patient. So this is important. And if you're not familiar in doing it, it'll be a bit difficult at first, but there are lots of YouTube videos to show how to do this. And you can watch and then you can do on a patient as you assess them, you'll get better. So the basis of looking at your velocity time integral LVOT, okay, this is it. So your LVOT is where your left ventricle outflow tract. This is where when your left ventricle is systole, it pushes the blood out into the aorta. So you can look at it as a cylinder. So the amount of blood flow through the cylinder can tell you your stroke volume during that particular heartbeat. So how do we get, as we know from maths, we can get the volume of a cylinder using a cross-sectional area times the length. You will get the volume of it. So your cross-sectional area, so stroke volume equals to your cross-sectional area times your volume, your velocity time integral. So to get the cross-sectional area, first you have to look at the heart in the long axis view, and you have to look at your LVOT. You take the measurement of the LVOT diameter from the insertion of the aortic leaflet. Okay, and you count the diameter perpendicularly, and that is your diameter. So your cross-sectional area. So cross-sectional area, you know, is pi times radius square. So if your diameter is, say, 2 centimeters, so your radius is 1 centimeter. 1 centimeter square is 1. So your times with your pi is 3.142. So your cross-sectional area for your LVOT is 3.142. So that is a constant. No matter if you give before fluid bolus or after fluid bolus, the diameter of your alveoli is going to be the same. It's not going to change. So if you look at the formula, stroke volume equals the cross-sectional area times velocity time integral. So if your cross-sectional area is going to be a static parameter, it's going to be the same. So technically your stroke volume just equals to your velocity time integral. You don't have to keep counting your cross-sectional area. So that's why we do the VTI. So we just have to look at the VTI, pre-bolus and post-bolus, and we can tell the stroke volume increases or not. So how do we do this? After you get your cross-sectional area, you go into the 5-chamber view of your heart. If you cannot get the 5-chamber view, you cannot do this. So when you get the 5-chamber view, you press the PW button on the ultrasound, which is your pulse wave Doppler button. The pulse wave Doppler button, the cursor, you put it at the aortic valve or 1 to 2 millimeter right above it. And then you press the pulse wave Doppler button again, and you will get the readings, the pulse wave at the bottom here. So this shows your blood flow through the tube just now. So what we do is, you need to measure this area. You trace the curve, and then the computer will tell you the value. Okay. So as I said, you pulse wave Doppler, your cursor, you put it at your aortic outlet here, your aortic valve, or 1 to 2 millimeter above it, and you will get this tracing. You can look at YouTube to get a better view and how to do it better. So once we get this tracing, what we want to do is, you want to measure, you want to trace out the whole thing, up to down, and then this will give you the measurement of the VTI. So a normal value is 18 to 22 centimeters. But there's some literature that says that normal value is 14 to 24 centimeters. But most of them say it's 18 to 22 centimeters. So what we can do with this information is, as I said, so now this is, let's say we're doing it pre-bolus. So pre-bolus, we get a measurement. And then after your bolus, either by a fluid challenge or by passive leg raise, you do another measurement. And then you compare whether the percentage increase in the measurement. If it's increased by 15%, that means your patient is fluid responsive. That patient can take fluid, okay? But you got to remember that giving a fluid bolus, IV fluid, is not just to find out if patient is fluid responsive, it's also a treatment for the patient. So if you're unsure, as I said, if patient as earlier when we checked the left ventricle and diastolic, we see the LV systolic function, we see the IVC. If patient is at the extreme, right, everything shows that it's hypovolemic. And probably, I wouldn't mind giving a fluid bolus to see if patient is fluid responsive. But if I see like the LV is like, the contractility is not that good, it's quite filled up, IVC is less than 50% collapsible. To see whether patient is fluid responsive by giving fluid, I'll be a bit cautious. So what we can do is the passive leg raise test. Okay. So later, the pitfalls of LV outflow variation will be further talked about by Dr. Hafeez. Okay. So this is your passive leg raise test. Why do we do a passive leg raise test? It's got very high sensitivity, 77 to 100%, and specificity of 88 to 99%. It can work both in an awake and intubated patients. Not necessarily the patient has to be ventilated to do this when we work. It is simple to perform, and you can do it as often as you need. So what the good part about this is, it redistributes the venous return from the lower legs to the central circulation. So this gives a transient fluid bolus without giving technically any fluids to the patient. Okay, so from doing this maneuver, you can increase the patient's volume by 200 to 300 milliliters of fluid. And the good thing about it is you're not giving extra fluid, and this is a temporary situation. Once you put back the patient in the normal position, the fluid goes away, goes back to your legs, lower limb. So how do we do this? So first of all, we put the patient is in a semi-recumbent position, 45 degrees. This is better to be done if we have the ICU bed then. The head can go down and the leg part can go up by using the control. But as you know, resus don't have that bed, so you have to use your own power to lift the patient's legs. So when the patient is in semi-recumbent position, you check your VTI first. After you got your VTI value, you you put the head down and you lift the leg up for 45 degrees. And you do this for 1 minute. After the 1 minute, you check back the VTI again, and then you see the difference. Okay, so this is what passive leg raise is about. So passive leg raise is contraindicated in patients with lower limb amputation that has pain on trying to tilt the patient's legs and also increase ICP. Please don't do this if patient got increased ICP. Yeah, please don't do this. Okay. So as I said, if your VTI pre and post bolus increases more than 15%, patient is fluid responsive, and patient has the ability to ascend your Frank-Starling curve. Okay, so basically, fluid responsiveness means, am I going to get an increase in cardiac output of 10 to 15% with the fluid bolus? Okay, so given the fluid bolus, you know patient is fluid responsive. Next, you want to know is patient is fluid tolerant or not. What is fluid tolerance? Fluid tolerance is you asking yourself the question, am I going to hurt my patient if I give them more fluids? Okay, so after you do your first bolus, you look at the SVV and all that, you say patient is fluid tolerant, fluid responsive. Then you need to see whether patient, he or she have had enough fluids or not. Can we give more fluids? How do we predict the adequacy of our fluid resuscitation? And will fluids be detrimental for patient at this point of time? So this is where you have to see you have to do your scans again, look at the heart, lung, and your IVC again. So let's say if previously I did a lung scan and showed it was A profile. And now I do a lung scan and this is what I see. B lines everywhere. Do you think you want to give more fluids to this patient? If this much of B lines, maybe not. But if minimal B lines, then you want to have to look at the heart again. And you have to look at the IVC again. So when you look at the heart, you look back at the LV systolic function again to see if the LV volume is inadequate already or not, your left ventricle and diastolic volume. And also you need to look at your RV. Sorry, I'm a bit illiterate when it comes to technology. Okay, so as you can see, when we look at the right ventricle, you can see the right ventricle is actually quite big and is pushing into your left ventricle. So what it tells you is your right atrium is currently quite full. Will it benefit the patient if I give any more fluids? Because as you can see, if your as I showed the diagram earlier, if your right atrial pressure increases, your venous return is going to reduce. Okay? And another thing you can look at is your IVC. If you see a plethoric IVC, you're going to think, I need to be cautious. Cautious. I might not, this patient might not need any more fluid. Maybe he needs an So this is just to assess the RV systolic function. This is just a bit of a extra knowledge a bit. This is to see your RV. So when you get a 4-chamber view, you can find your, let me get a pointer. Okay, this is your right ventricle, this is your right atrium. So you want to use in the M mode, and you want to put your cursor right here at the free wall of the right ventricle. Okay, this is called your, technically you're looking at your topsy, your tricuspid annulus plane systolic excursion. Okay, so this will tell you whether how your RV is functioning. So once you put the cursor there, you use the M mode, and you will get this kind of waves. So you will count the diameter from the top of the wave to the bottom of the wave. That is how you get your topsy. Okay, so the normal value is 16 millimeter to 32 millimeters. If it's less than 16 millimeters, it means that your RV wall is hypokinetic and it's distended, and probably the patient will not benefit from any more fluids at all. And then and you look at your RV, and if you see a D-shaped septum, it shows that your RV is already dilated. So this is how you assess for fluid tolerance. So once you see B lines, when you see IVC is plethoric, once you see your RV is dilated, you probably think that patient cannot tolerate any more fluids. So how you want to determine whether the patient is still fluid responsive? You go back and do your VTI and your passive leg raise test again. Okay, with the passive leg raise test, if there is a stroke volume increase by 15%, patient still can take fluid. You can still give, but you just have to be more cautious, because in a septic patient, their vessels are very leaky. So you give even just a little bit extra fluid, it's not good for the patient. It will cause pulmonary edema, ARDS. Okay. So an increase in RV size with no increase in stroke volume is stopping point for fluid administration. Paradoxical septal wall motion demonstrates very high RV pressure. So this is just a diagram to tell you what I just told you, basically the workflow of what you're supposed to do. It's a bit small, but later we'll put the presentation in WhatsApp. You can look at it. And so the bottom line is assess volume responsiveness before deciding on giving fluids. Look at the heart to assess structural abnormalities. And do not forget to incorporate clinical assessment into your clinical decision. I have to tell again that this one assessment is not enough. You have to look at the whole big picture, look at the clinical assessment of the patient as well. And with this, you confidently can treat your patients. Thank you.
Right, thank you, Kiran, for the presentation. We will just continue for a couple of minutes, right? Hopefully not too long, and hopefully we don't bore you too much. Now, we know it's a bit technical. Now, a lot of things are more relevant if we practice it, right? To some, it might be very relevant, okay? Especially when you're resuscitating patient in resus, but of course, we have to practice, and then we will know what we want to focus on, what we don't. Right. So the important thing is is this slide that we showed earlier. This protocol that we showed earlier, this pathway, is an algorithm that we took from that paper down there. Right. Now, so it says now most of the time what we think about when we see a patient with hypovolemia is we consider all the shocks, right? All the type of shocks. Now, so if this patient is really hypovolemia, right? So we no longer think that all of our patients need 30 cc per kilo crystalloid bolus, right? They might if they have severe hypovolemia, right? So BP is very low. I do not need to scan to know that I need to give at least 10 cc per kilo first. Right. So now, say they have oversized hypovolemia, right? So we have to give bolus, fluid bolus at least, right? Okay. Say they don't, right? So they do have hypovolemia, a bit of hypovolemia, not too bad, right? So now we have to determine is this patient going to respond, and is it going to be tolerant, and is it going to be safe to give fluids to the patient? Now, if we read through the algorithm, then we will notice that a lot of things need VTI or stroke volume correlation to proceed and for us to decide to give bolus or not. Now, fluids or not. Now, so the important thing is how good are we at doing our VTIs? Now, to be honest, I'm not good. Right? I feel at the first step of a lot of times getting the good 5-chamber view. Now that's kind of difficult, right? Right. Now, so a couple of papers are written to address this issue. Now, even our VTIs, what are the issues of getting a good VTI, and does a VTI accurately reflects the patient's stroke volume or cardiac output? All right. Okay. Now we go through 5 things here. Okay. Just bear with me, right? Now, first things off, right? So image acquisition. Now, I'm learning too, so don't ask too many questions, right? Now, so what should we pay attention to? Now, number 1 is angle of insonation. So the angle of our probe hitting the LVOT. The second thing is sampling location, and the third thing is tracing error. This is point number 1, right? So we're going to dive in depth into this, right? So angle of acquisition, insonation, right? So as you can see here, it shows that right, if you have your probe directly at the angle of the flow, right, of the LVOT flow, so you can have a very good Doppler reading. Okay, or pulse wave Doppler reading. But if you angle it more than 20%, so your error of your VTI reading reaches 13%. So it goes larger if you angle it a bit more, right? So if you angle it at the right angle, then you won't get anything by right. Okay. Now, so how? So as you can see here, so you have a 5-chamber view. This is an example, a 5-chamber view with a good LVOT trace. Okay. This is a good LVOT trace. So what signifies a good LVOT trace? So this is a bad one. Okay, this is a bad LVOT trace. This is a good LVOT trace. So what signifies a good LVOT trace? Your tracing should be narrow peak. The inside should be a black blood flow. Okay, and also you need to see the aortic closure. All right, so that would be a good LVOT trace. Now, so as we mentioned, this is a bad one, right? We don't want to get this and measure it, then we'll get a wrong VTI calculation, a wrong stroke volume, and then subsequently wrong move in our management. Next, we have sampling location, right? So this is a good sampling location. So as Dr. Kiran mentioned, so you have your pulse wave gate cursor just above the aortic leaflets, right? About 1 to 2 millimeters above, right? So if you place it too much, then you cannot get accurate reading. You place it too far in, you don't get accurate reading. Now, if you place it laterally and you hit the tissue, then you're going to get a different reading too. All right. So your reading depends on the place you put it as well. Now, the third thing is your tracing itself. Yeah, our tracing itself. Okay. So we don't trace it all the time. Okay, we don't have the automatic tracer system, right? We have to pay a couple of thousands for that to be installed in our ultrasound machines. So now this tracing is a bit big, isn't it? So you get a big VTI, a huge VTI, right? So the actual tracing is kind of like that. So actual VTI is actually about 13.9, right? So that's different. So that's important too, right? So three things, okay? Now the fourth thing is actually the tracing error. The fourth thing is actually tracing the wrong thing. Now, do you realize why is it wrong here? Why is this tracing a wrong tracing? What do you think? Can we ask Swahili? We need an echo plus from Omar, but say yes. Perfect, right? So now this tracing is after the aortic valve closure, and also there's a mitral inflow here. So you know that this is not the tracing of the VTI. Okay? Right. Now, so recap again. Angle of insonation, Doppler angle need to be parallel to the blood flow. How to get that? Okay, a good tip from the YouTube videos and from Omar and whatnot, right? All right. So the good tip is you get a good 4-chamber view. So yeah, your ventricular septum need to be in the center, and the apex need to be seen, right? A good 4-chamber view, and then you tilt your echo tail downwards. So your probe will go straight into the LVOT, right? Then you need to make sure that your tracing is a good trace of the VTI. As we mentioned, a good trace is number 1, narrow negative flow peaks. Okay, the one you're tracing. Number 2, bright envelope with dark blood flow inside. And number 3, that you can see the aortic closure there, right? So, and then to another recap, we need to make sure our sampling location is just proximal to the aortic valves, about 1 to 2 millimeters. And also make sure that we trace properly and we trace the right thing. Okay. Now, pitfalls number 2. Okay, now, even if we get a good VTI, now the rule, the two important things to make sure that our VTI is actually a VTI that can calculate our stroke volume is the LVOT need to be cylinder shaped. So if we have a dynamic LVOT obstruction, per case Hookham, or in hyperdynamic cardiac contractility, you have an anterior mitral movement, so you don't have an actual cylinder, right? Number 1. Number 2, we need to be able to measure the blood flow itself, right? So the issue with that is the blood flow, sometimes you have very chaotic blood flow, so you cannot actually get an actual VTI reading, right? So we cannot measure the stroke volume. Okay. So this is what we mentioned. All right. Now, number 3 is if we have a regurg. Okay. Now, the issue with regurgitations, aortic regurgitations, it means that usually when we measure VTI, we presume that our stroke volume is everything that comes out of the ventricle. Now, with moderate to severe aortic regurg, what comes out, a percentage of that comes back in, right? So you're not measuring the actual stroke volume. Okay, bear that in mind. So that's why we see a lot of our experienced physicians, they scan and they check, is there any aortic regurgitations or not, and how bad it is, if there is, right? Now, number 4 is, of course, arrhythmias. So how do we go about it? So we need to measure 4, 5, 6, a couple of them to get a mean of the VTIs. Okay. Now, number 5. I'm counting it wrong. But all right, number 5. All right. So now a VTI can can translate into a stroke volume, and a stroke volume can translate into cardiac output. But we need to bear in mind that we're not actually calculating a stroke volume per se. So when we're doing an intracardiac measurement, okay, we're doing an echo, a non-invasive management. Right. So what we're doing is we are looking at, see, we have a low BP patient. Okay, these are our usual formulas, right? So on top there, okay, out of the screen, that's your oxygen flux. Okay, so go back to that. That's fine, right? So now we have a low BP patient. Our MAP is our cardiac output and our systemic vascular resistance. Now, bear in mind, okay, our septic patients, okay, they might have good cardiac output, okay, because they have good heart contractility, good volume, okay, but they have a high heart rate, tachycardic, but they have low systemic vascular resistance because they're septic. So then you get low MAP. Now, calculating your SVR is another important thing to do, but we leave it for another day, or we leave it for the echo course. But that's fine, right? Yeah, but if you find it low, then maybe you should put a vasopressor in. It would be more beneficial for the patient. Now, so a cardiac output is this stroke volume times heart rate. So if you have a normal stroke volume, a stroke volume is LVOT divided by 2 to get your radius, and then square that times pi and times your VTI, right? So a couple of things that we need to take note, right? A VTI, a normal VTI is a normal VTI for a normal LVOT. So a normal LVOT is in the mean population is 1.8 to 2.2. Anything under 3 is still normal, but a normal VTI for them is higher than the normal VTI that's agreed on, right? Right. So we take for example, right? A VTI of 14 and LVOT of 2, right? You get a stroke volume of 44. Okay. So you think this VTI is low, but again, if we calculate the LVOT and it's actually 2.5, then our stroke volume is actually 69. So it might actually be normal. So that's why it's important to calculate the LVOT to get the actual stroke volume. Just the VTI is not enough. But do we need to calculate this LVOT every time? No, right? Because the LVOT is fixed. It cannot, will not, should not change size. Okay. Now, so of course that plays a role in our VTI variation. Okay. Right. So that is the point that I was highlighting. Now, next, our cardiac output. So even if you have a normal stroke volume, with a low heart rate, we still have a low cardiac output. But then we can get to the problem. So we know the problem is the heart rate now, if you have a normal cardiac output. So tackling this, then we are able to address the actual issue of our hypotensive patient. Of course, there's our rush protocol, our high-VAC protocol, and our protocols for shock patients to determine which kind of shock are they in, right? So that's what the pitfalls for the VTI, the importance to do a VTI. The take-home message is we need to practice more, and practice more. No questions are allowed. All questions should be addressed to Dr. Omar Koyo, but that's okay if you have questions. Thank you very much. I presume we don't have a question, but we have food. Don't worry. Dr. Sahititisu, as you have announced, we will check. I hope he's not, but that's fine. Okay. he checked our slides. Don't worry about it. We might have rumbled more, but yeah, but he's not.
Assalamualaikum warahmatullahi wabarakatuh. Saya rasa kita ada a few new MO ataupun MO yang pernah bekerja di sini dulu. Tapi sebelum tu, I'm sorry for the topic. I realised that this topic is actually quite heavy lah. Okay, it's master's level, and some of it even some of it even not expected for you to know until final year. The numbers kan sometimes, actually kalau according to the Prof Madia Dr. Syafari, tak perlu pun you all tahu the numbers tu. Because ultrasound in ED focus means it's just a yes or no. Okay, that is what the level that we should know lah. But of course, knowing better is good to know lah kan. Okay, so can I just summarize because it's very heavy and I thank children and Hafeez because I have a very good slide untuk orang yang tahu. For the units that can just summarize for you, so this is very detailed lah sebenarnya. So can you by now after listening to Dr. Kiran and Dr. Hafeez's presentation, can you all summarize what is the difference between fluid tolerance and fluid responsiveness? That's right. I nak summarize balik so that you all faham. At least get a bit of something from this CME lah. Whatever this what I have. That's right. Tak tahu apa-apa. Saya sebab scan kan. Bila dia setakat I semalam kan, I have to read balik my notes to make me understand. Jadi Ana sudah tamat atas ni. Ilmu memang banyak. So if I can just summarize, saya nak jawab dulu apa yang awak faham. Nampak ke? Sampai dia buka dalam. So you ada fluid tolerance and fluid responsiveness, right? Okay, an easy way is this is not my forte, so I have to study quite detail juga untuk faham in a simple way lah. So I hope you can understand as how I understand it. And if I'm wrong, that was okay. So fluid tolerance, first you want to know is the patient tolerant or intolerant to fluid. So macam mana you all tahu is satu you tengok IDC lah kan tadi. So kalau dia flat IDC means dia still tolerant lah kan. Kalau dia punya IDC dah categoric fat IDC means maybe dia intolerant, then you have to assess for fluid responsiveness. Another thing adalah you can check for EF ataupun contractility. Kalau dia hyperdynamic or normal, maybe this is tolerant to fluid lah. Usually it will tolerant to fluid. So either hyper ataupun normal. But if the EF is poor, macam Kiran cakap tadi lah kan. Okay, so walaupun dia poor, not necessarily the patient doesn't need fluid. Contohnya, patient ada heart failure, EF dalam 30%. Previous primorbidly datang ke apa je patient juga splat kan. How do you know? Patient memang dilated semacam apa kan. So how do you know patient is fluid responsive? That is how when you need to assess for fluid responsiveness. Faham tak? Okay, apa lagi yang kita cakap? Lungs. So you can scan for lungs. Kalau dia dah tak ada, kalau dia memang A profile, means tak ada evidence of in the lung. So still tolerance lah. Kalau dia dah ada B-lines yang bukan localized lah kan. Kalau localized itu pneumonia. Okay, so kalau B-lines generalized, maybe patient dah overload lah. Okay, so if you have all these, I think this is untuk MO. I think you all can do this scan kan, most of you. Sebab I think most of you dah pergi basic ultrasound workshop. So kalau dah ada semua ni, actually you can already decide by clinically patient is fluid. This confirms that patient is fluid tolerant, then you can give fluid by all means. But then afterwards you have to assess lah. Okay, after bagi 1 liter you have to assess balik or maybe 500 ml kalau you over it. Okay, so kalau one of your scan ni, actually dia ada lagi lah, tapi this is more detailed. So you ada RV function and diastolic function. Okay, so yang ni agak mana touch sebab nak buat benda ni, tapi I think kira dah touch lagi pasal tak save. Okay, so kalau you ada RV function, contohnya RV is directed. Okay. RV is directed, you nak bagi flip ketak. Sama lah macam RV ni tadi kan, kalau macam tu, not necessarily patient would not respond to flip. Okay, but you have to be cautious lah. Kalau untuk diastolic, this one is higher up. Okay, practitioner correct mengajar lah pada dekat USM dulu. But even he mentioned, you don't need to know that for final year. Good to know. Tapi for exam tu tak masuk dalam data. Okay. Examiner dia tanya. Okay, so diastolic ni, actually I think this is the way to go lah. Diastolic ni beza dia is preload you tengok dia punya dia masuk pada right side of the heart kan. Okay, so diastolic ni kita nak tengok preload of the left side of the heart. Okay, so kadang-kadang tapi dia tak masuk sampai ke left ventricle. So your area sebab whatever comes to area all your body kan. Okay, so that is what diastolic is about lah. You akan baca. Okay, so all the EA prime whatever semua tu. Okay, so I believe this tree is good enough. Okay, so let's say you scan patient datang is low, obviously you are going to check lah nanti below. And clinically assessment, does the patient is fit? Okay, and then you confirm, oh semua okay. Then dapat fit dulu, then you assess. Tiba-tiba you scan, dia poor. And I still fit, takut dah nak bagi kan. Dia 20% je. Patient dah tak berjaya klik, betul dah nak bagi. What you can do is move forward to responsiveness, which is your PDI tadi kan. Ataupun kalau nak baca lagi, actually lagi senang lagi clarity DPI, I pun tak sempat belajar rumah. So I perasan you all DPI pun macam ada yang pandai lah, sebab kita ada ultrasound yang automatic detect kan. Okay, but make sure you get a nice 5 chance of you for the Deparment. Okay, DPI ni dia mesti like erase ataupun frivolous kan. And then IBC variation also is one of them lah. Tapi it's not as good as PI lah. Okay. And ada banyak lagi lah of variation semua. Tapi that is my end. So as far as you understand, responsiveness, bila nak panggil EP, oh saya rasa saya risau lah patient ni boleh respond to fit lah. Maybe dia dah intolerant, dia responsif tak. Jadi dia akan tahu lah. Okay. So this is whether the patient can be given fluid or not. This is the patient. Faham tak? Jadi anyone yang tahu? Apapun soalan dia, kita ada, by the way, I suka satu ayat ni. Apa nama yang selalu sangat kita balik is kalau semua orang kenal dia adalah one of the ultrasound punya orang kan. So dia saya cakap ultrasound is a tool, not the tool. Okay, so always your clinical examination comes first. Always the clinical examination lah. And then since you all dah belajar dekat sini, and I ingat masa kita tengah COVID dahsyat dulu kan, banyak kena access split ni especially. Maybe sekarang dah kurang orang sikit, maybe boleh belajar lah. Especially kita ada importers ni orang Dr. Umar Kaurium lah. I pun still learning Dr. Umar all these VTI things, tapi tak sempat habis. So please grab him and belajar sebab the only way untuk buat benda ni is when you do it on patients. Okay, and you have to start with normal patient dulu. So bila dapat yang very bad patient, dah dapat kind pun susah kan. Okay, then we do everything that's the skill lah. Okay. Okay, so basically what Dr. Afifah explained tu betul lah, tapi untuk simplify, actually fluid tolerance tu you screen. Fluid responsiveness you assess, tu je lah. Ya, you screen first, patient ni layak tak nak di assess. Macam masters lah, you hantar orang kita pergi rumah kah, layak tak? Bila dah layak, dan baru kita bagi interview. Sort of lah, lebih kurang kan. So that is the simplified way. But anyway, again, it's good for you to practice, but again, always remember back when you're in medical school, 70% is always from history. Yeah? 20% is from physical examination, then the other 10% is a tool, which is ultrasound, and also, of course, X-ray. For us, ultrasound is actually bedside. So you guna juga masa physical examination tu nak masukkan sekali boleh, but please don't miss the history. History part is very, very important. Sometimes with the accurate history, then you boleh dapat certain, you dah screen, then baru you got fluid tolerance kan. Certain, you don't even bother to buat ultrasound and fluid tolerance, you don't even waste your time because dari history you dah tahu dah. And then for those yang datang kat sekolah dulu, kita dah ada notes kan. So you can actually trace the notes pun kadang-kadang dah cukup dah. But of course, you're most welcome. Kalau patient dah tak banyak, selagi kita tak hybrid, in January most likely lah kita akan hybrid. So take the opportunity to learn as much as possible. And again, I always think like this: the best way of learning is to teach. Alright, so as a student, there's no way that you're running away from teaching. You have housemen to teach because when you teach, you belajar dua kali. Because to teach, you have to learn first. Right, it's something like it's a force. Contohnya macam Kiranjit, kalau dia tak perlu teach on hari ni, I'm sure dia tak go through in detail on this, right? So the best way is to teach. Alright, so today 1st December, usually 1st December is the start of certain people, they start duties, all that. So we do have new members which we are honored to receive and welcome. So probably boleh introduce macam Suhaila, certain orang boleh memang dah kenal kan. Certain people, I always forgot the masters from UM sebab second year baru dia masuk. Third year tu macam at least 2 years dah dapat lah. UKM first year dah masuk kan. So maybe boleh introduce.
I'm Dr. Kyo. I just came here today. It's my first day. I did my first year in UM. So this is my second year. I will spend here 2 years. So I hope you guys will teach me. Yeah, I'm willing to learn from all of you. Before that, I did my MOship in Sandakan and I housemanship in HPP, Rapina. Thank you.
Assalamualaikum and very good morning. I'm Suhaila Naimah, tapi sini orang panggil Naimah sebab kita ada Siti Suhaila. Okay, I just entered back for 4th year from UKM Sydney. So hopefully we can learn together lah. Exam in December, right? Sama dengan Randy dan sama dengan for next year kita tak ada intake on June, so intake will be in December juga for the first year. Right, 2 years consecutive kita punya intake is on December. Okay, so kita akan ada seorang lagi pakai yang akan buat duty, which is Dr. Sabiha. Some of you all memang familiar sebab Sabiha was briefly MO actually for about few months, right? And then dapat masters penempatan dia out campus is actually dekat Ishtar. Okay. And then dia Sabiha is under UM,
Then dihantar biasalah, dihantar ke Sabah, and then she just came back. Siapa yang pergi ke Sabah tu usually after 2 years dah balik, so she get back here. So sekarang dia kat JPN, petang dia akan datang lah. I think you will know which one is Dr. Salihah. And she's planning to apply for PAM. PAM is Pediatric Emergency Medicine. So kalau dia dapat, probably 3 months je lah kat sini, and then after that dia akan start buat rotation juga lah. And the other person yang kita honored to receive is actually Dr. Hafeez. So sebenarnya kita tak CV dia, tapi tak apalah, saya introduce apa yang saya tahu lah. Dr. Hafeez is very senior. I think 1 year junior than me sahaja, right? So she has been in HTAL for more than 10 years, 11 years. And then she's applying to transfer ke Singapura, which is okay, because rumah dia dekat dengan sini je, dekat Puang belakang tu, right? And she's also a member of Infocus. So sekali kita saya seorang Dr. Professor juga, so we hope to learn from her as well and to get experience whatever in HTAL. And then sekarang ni kita dah ada link lah HTAL, right? Okay, so anything Dr. Professor nak tambah ke? Ada. So we are honored to receive Dr. Professor in this hospital Singapore. So Alex, saya lupa nak tambah lagi seorang master student. Berapa? Itulah kan. Alright, so ada apa-apa soalan? For this one, it's very, very good again for you to know. But kalau you rasa macam long sekejap tu, don't be worried. Yeah, it's okay. You can learn long the time dekat sini. Take the opportunity to do the ultrasound. Tapi yang basic-basic tu kalau boleh tahu lah, because those are the requirement for us to assess. And then for your information, sebenarnya dekat sini kalau you tahu ultrasound, when you refer, is very good because the primary team will always ask your opinion. Dia terbalik sikit kat sini. Yeah, when it comes to assessment all this, they akan ikut cakap you on, provided you actually have your own confidence. Sometimes, again, your knowledge sebenarnya lagi tinggi daripada primary team. Because remember primary team sekarang ni, dia orang kat COVID pun. Dia orang tak buat semua ni. So they need your opinion. So it's good for you to do all this, and at the same time when you refer, they will actually ikut cakap lah, bukan akan ikut cakap. So there's always a room for professional discussion. But through my experience, sebenarnya they actually trusted EMO on this matter lah, right? Okay. Anything to add, pakar-pakar? Umar Kayu nak masuk?
Umar, ada apa nak tambah? Tidur lagi tu.
Assalamualaikum, tiada Dr. Su.
Dah terus keluar. Okay, dapat anything else to add?
Tiada Dr. Su, saya rasa apa yang Kiran present tu dah cukup dah.
Dah cukup. Okey, Dr. Umar kata dia kata yang present tu dah cukup dah. Kalau dia nak add, I think sampai besok pun tak habis Umar kan? Okay. Alright, so anything else, Alex? Anything to add? Kita ada flomo juga kan? Ada tak flomo hari ni? Dekat sini tak ada to introduce yourself. Houseman baru tak ada? Okay, maybe you can introduce yourself. Okay. Okay, dah jumpa belum? Okay. Okay, right, so tangkap. Okay, so kalau tak ada apa-apa, saya rasa makan ada tadi, ada bau sikit. Ada makan. So again, jangan lupa penjarakan sosial. Please take care of your SOP bila makan. And then probably for master, lepas tu ada teaching kan. Yeah? Alright. Okay, Emilia, ada anything to add? Khalid? Nothing, tak ada? Alright. Thank you to the group E for the excellent presentation.
Mantap, mantap.